Thank you so much, sir. And I'll go straight into what is the role of OCT in glaucoma. We all know that glaucoma has come a long way. So from, just think about it, 1991.
Before, 1 second, Sagarika, is Dr. Richard Gale here? Yeah, okay, thank you. I think maybe we'll take you up after this lecture.
So we've come a long way from 1991, where we didn't even see the first two OCTs, and now we have come down to swept source OCTs, and we are awaiting a lot more into our armamentarium. It's a non-contact, non-invasive imaging technique. It's very useful for the diagnosis, prognosis, progression, and many other things which I'm going to talk about. So I'm going to talk about a serving soldier who was a serving officer, who was 57 years of age. He had no family history of glaucoma, no history of myopia, did not suffer from any eye diseases, was not on any systemic long-term medication, no history of trauma. But when an NCT was done for him, it was found that his right eye pressure was 31 and left eye was 22. This was again repeated by means of applanation tonometry, where we found that at 8:30 in the morning, it was high, 28.3 is high in the right eye, and so again repeated, it was 25. Left eye was just about marginally okay. His Humphrey visual fields were absolutely normal, and he, because it was in 2010, then was taken up for the straightest time domain OCT by Carl Zeiss. It's very easy to see that where my marker is there in the blue, that there is a definite area which is borderline. Now, the axial resolution of this OCT is only up to 10 microns, 10 millimeter. We find that there is significant inferior retinal RNFL thinning in the right eye in comparison to the left eye, depicted by yellow color. Is that significant? Of course it is, because we know that structural loss precedes functional loss. So you might find that the field is absolutely normal, but OCT is giving us some information. Some further information. Have a look at the rim area, right eye and left eye. In the right eye, it is the rim area which is so important, the NRR which we talk about. It is only 0.53 millimeter square, whereas the rim area in the left eye is much more, almost double. Therefore, telling us definitely that this patient's rim area is less in the right eye. Again, confirmatory, we have a look at the optic nerve pictures, and we find that there is an inferior notch in the right eye in comparison to the left eye. So what does OCT help us do? It helps the glaucoma specialist for diagnosing. It also lends support to us to start our treatment. We go to a second case. So this was a 42-year-old female who complained just of headache, very vague symptoms, and the patient's NCT was normal, that this person was myope in the right eye, not very great, but yes, high cylinders, and also in the left eye, she had hypermetropia. But the specialist concerned found that she had large optic discs, and I have drawn in the next picture, these are my drawings over here, which show that the abnormality of the optic discs. She had absolutely open gonioscopy, open angles, and the pupils were normal. The question was, does this patient really have glaucoma? The CCTs are thin. It is only 452. We all know that in Indian eyes, it varies between 530 to 550 microns. Gonia's open angles, fields are normal, in IOP is normal. Now we go to OCT, and we have a look, and we find that the OCT in the right eye over here, we find that there is no hot color in the inferior part, and so also in the left eye. Now let's have a look at the pictures of the optic discs, and you find that the right eye is looking more or less normal, but there is a huge area of PPA out here. We can find that there are good retinal nerve fibers present out here. In the left eye, it's an absolutely abnormally shaped disc. Whereas the RNFL, when we look at the RNFL, we find RNF is normal. So this is definitely an optic disc tilt torsion in the left eye, large PPA in both the eyes. OCT does not have normative data of such discs. Therefore, how do we now diagnose glaucoma in such cases? Diagnosis of glaucoma depends upon serial AT fields and serial OCT, because now this patient's OCT becomes the baseline for this patient, and we go ahead and keep on doing serial OCTs as and when the patient comes, when we call the patient, and then we check back. Now, we have to remember a very important fact is that check the signal strength of every OCT that you're looking at. This is an RTVO OCT where we know as per the manufacturer, it should be over 40. In this patient, we found that the SSI in the right eye was 55 and in the left eye was 31. And we also found that the average RNFL thickness in the right eye was 58. We all know that average RNFL should be approximately 98 to 100 in Indian eyes, and the left eye was 98. We also realized this, that the difference of 9 microns between the average RNFL thickness between the right and the left eye, you should be closely followed. Now, look at how the signal strength affects the OCT. This is one patient for whom the OCT was done, and this is where the signal strength was only 41 in the right eye. And of course, the patient came to me saying that the father said, the patient has glaucoma. Please, ma'am, have a look at it. And when we did it again with a better signal strength, the patient was absolutely normal with normal signal strength. Same thing, another patient where we find that again, the right eye is showing that there is definite RNFL thinning. Again, you do a very good signal strength and you find it's absolutely normal. So this is one thing that every glaucoma specialist should definitely have a look at. We must understand that some OCTs give us a lot more information, like for example, the RTVU. In this, it has a patented FLV, that is focal loss variance. It measures the amount of focal loss over the entire ganglion cell complex. And mind you, the GCC in different machines covers up different areas. That's very, very important. Let's look at another case. July 2018, 61-year-old male. Vision was, the patient had, of course, myopia, left eye more, and we find that in the examination, he had NRR, loss was present definitely inferiorly out here. And you can see another thing, there was a splinter hemorrhage, and the pressures were absolutely normal. Correspondingly, we find that the field had a definite defect in the right eye superiorly, and then look at the OCT, we find there was definite thinning in that corresponding area. We went into 2019, again, same defect, left eye absolutely normal. 2020, now the defect has started enlarging in the right eye. Left eye is absolutely normal. And you see, the OCT is also telling us, hey, look, we become borderline in the right eye, left eye is still normal. And then in 2020, absolutely no change in the right eye, no splinter hemorrhages. But in 2021, we find that there is a slight increase in the field effect in the right eye. Left eye is absolutely normal. But lo and behold, what does the OCT tell us? That the right and the left eye RNFLs are definitely disproportionate. I mean, they have also been affected. The pressures were normal. Patient was on lacnoprost. Then why is it that the patient has got a structural defect also appearing in the left eye? The IOP is controlled. Is the blood pressure under control? So imaging was done. The patient now suffered from hemiplegia. What is to be understood that this patient had infarcts. Astrani in 2024 has said that decreased thickness of the RNFL and GCL has been reported to be correlated with the extent of cerebral small vessel disease on MRI. Along with that, it can also occur in many other diseases like kidney disease, etc. Now, Holter report cardiology was absolutely normal. A 46-year-old lady who was a hypermetrope, look at her axial length, 21.75 in the right eye and 21.83 in the left eye. Unable to do fields, which a lot of our patients are unable to do. So I had a look at, clinically we found that the optic discs were relatively small. Tried to correlate it with the OCT finding of the disc area, we found it was approximately 1.71 millimeters. And we all know that this is definitely a small disc. A small disc should have practically no cup. In this patient, the patient had a cup. And you look at this now this is, oh my God, I'm so sorry. This patient, of course, the field, the OCT which I'm now showing you is not of the OptiView, but this is of the newer OCT which we have just got, and that is of the NIDEC OCT, where we find that the right eye is showing that there is definite thinning. Only 71 microns is the number of the RNFL in comparison to the left eye. And also the GCC, which is present again, I've marked it by by the blue arrow, which is telling us that there is definite a diagnosis of glaucoma in the right eye. So what does OCT do? It's an objective method to determine if the patient is progressive, if the patient is unable to do fields. So this is a very good method. A 56-year-old lady, we get lots of them, who are very high myopes. Now, in 2010, she was found to have approximately 16.5 right eye, and in the left eye, 14.5. and her pressures were normal, CCT was normal, gonioscopy had open angles, and she underwent LASIK. And then, of course, her corneal thickness decreased. She was put in Latoprost in 2014. So this patient is a case of high myopia, follow-up from 2010 to 2025. I'm sorry, I have finished time. Can
you another minute or so?
Okay, sir. So look at the axial lens, 29.65 and 28.11 millimeters. Look at the various types of OCTs that have come with the patient. 2010, stratus. 2014, RTView. 2016, RTView. But everywhere it is telling us that the right eye is the damaged eye, and then subsequently left eye also is showing damage. Then in 2019, same thing. But now we come down to the NIDEC. NIDEC gives us, this is a special thing that it gives us the axial length is included and Asian descent. Remember, we cannot have Caucasian data into we can't compare oranges and apples. So it's this Asian descent was included, and we find that there was both RNFL as well as macular thinning. And these are her fundus pictures. This was another patient. You'll find that in myopes, there's a lot of truncation which happens in the OCT pictures, so be careful about them. There was another patient who has got unilateral advanced glaucoma, OCT differences. Now look at this. This is the Cirrus OCT. Have a look at the signal strength. Not at all good in both of them, but it is definitely showing us that the hot colors in the left eye have gone. It's a sea of blue. And then again, the patient comes to us with the RTVU. We find that definitely the left eye is the affected eye. And then he goes on to the spectralis. That also tells us that definitely it's the left eye which is the affected eye. So we have to also understand, little children, 6 years old, 7 years old, get referred to us as a case of query glaucoma. Please understand, we can do the OCT and use the patient's own data without using the normative data in order to go ahead and diagnose the case and follow up the case. This is a case of papilledema. One must have a look at the clinical features, mediated nerve fibers, all of which give us a very good idea about whether a patient is actually having glaucoma or some other disease. Nothing can prevent us, or rather, we have to have a look at the clinical findings before we just go along and take an OCT and say that this patient has glaucoma. So don't treat an OCT. A comprehensive ocular examination is an absolute must. Search for causes of retinal thinning. All may be not due to glaucoma. Glaucoma may coexist with various diseases, and other investigations, including CCT, DV, are very important, with emphasis on history and risk factors. Thank you so much. Thank you, sir, for
Thank you,
giving me
Dr.
that extra
Sagarika.
minute. Thank you, sir.
I think one thing should be clear. I mean, while we stress on OCT with retina, but remember, the retina will destroy the macula and the central field. The glaucoma will destroy the peripheral field if you are not careful about that, and if you miss glaucoma in the presence of a retinal disease. Absolutely. So I consider it equally important that when I'm evaluating a patient for macula, should also make sure I don't miss the glaucoma. And the OCT for RNFL is an important part of my workup for retinal disease also. I think one message was clear, was that when you're evaluating the OCT, check the signal strength. If the signal strength is not good, you could get a misleading picture. That's one. The second thing is, changes in OCT can give you the basics for screening with a field, which takes much longer. Yep. And thirdly, if you have a situation where the OCT on a sequential follow-up is showing changes which are increasing, you may use it even for treatment.
Absolutely, absolutely.
Also. In addition to this, if there are any other questions from the house, please go ahead. Do we have any questions from anyone in the audience?
What about AIOS2025 in glaucoma?
Yeah, we have AIOS2025, but sir, I would definitely place my bet on gonioscopy, and a proper good gonioscopy done in the correct methods, that having a semidarchrome, etc., before I say that place my bet on an AIOS2025.
I think for a general ophthalmologist who has an OCT within anterior segment OCT, to rule out angle closure, it may be a great idea, especially if you don't have a glaucoma specialist around you. So yes, I think that makes a difference also. It may not be the best way.
I appreciate your comment. I appreciate your wisdom, and I admire it, but I still stand. You cannot replace gonioscopy with any other tool.
No, I'm not saying you replace it. I'm just saying that you may not be as good with a gonioscopy. as a
That's
basic
okay.
screening.
But the unfortunate
as a
thing is that
basic
too many
screening tool.
PIs are done
Yes.
just based on the ACE
so,
OCT, which
so
is wrong.
not that you do a PI, but I would not dilate if I have a doubt.
Yeah,
Which even today, even if I have a clinical doubt, I first get a gonioscopy done. Now, if you're alone in your clinic and you have this, at least you can check out whether you should take a chance or not.
I think we should stick to gonioscopy. Already biomicroscopy skills have come down based on the OCT. Indirect ophthalmoscopy skills are coming down. I think better.
Yes,
to
so our
at least
skills are
learn
becoming
gonioscopy.
less. So that from that point of view, it's better to have.
I think there was
Can
a
I,
wonderful thing on obituary for
yes.
the of the clinical findings. So it's
Yes.
very important
So
for us to do.
Thank you, Dr.
Thank you.